Good morning, Dallas. It is such a pleasure to be here with you virtually, to be able to talk about my true passion this morning on cardio-rheumatology. I know it's bright and early there, and I am at the hospital when you're watching this. I'm on inpatient service, and I regret I cannot be there in person, but I will be seeing you live very shortly after for the discussion, and I hope to really be able to engage with you. So thank you for the opportunity of RheumNow to really be able to discuss this topic. So I will jump right in and be just talking about the emerging field of cardio-rheumatology today. Here are my my disclosures, none of which are relevant for this talk today. And so to begin, it is well appreciated that cardiovascular manifestations within patients with systemic inflammatory disorders is vast. There are multiple diverse manifestations. I like to put these in broad buckets: vasculature, the pericardium, valvular, myocardium, and electrical. And if you are to sit there and think about all the diseases you take care of and all the patients you take care of, you can see that there are multiple different cardiovascular manifestations, ranging from accelerated atherosclerosis all the way to pericarditis, myocarditis, and arrhythmias. You can see the vast complexity of what we're dealing with. Furthermore, when we talk about medications, we are becoming increasingly complex. I always say to my colleagues in cardiology that rheumatology is far advanced than we are in terms of all the advances in the medical therapies, but there are certain challenges that we're dealing with in 2023. I still remember in my clinic in 2020 during the COVID pandemic at the height, where you probably remember this as well, we were all concerned that our patients would not get hydroxychloroquine due to the shortage. And after that, there was a whole flurry of concerns about cardiac arrhythmia problems, which led to a lot of great investigations to really investigate this. One of the more common examples now in 2023 is actually something we all struggle with, is with the black box warning that came recently after the FDA added it to the JAK inhibitor label. And it really creates a challenge to be able to understand how and when we utilize these therapies for our patients who need them for their systemic inflammatory disease, but also have cardiovascular risk. And then one of the bane of my existence, I say as a cardiologist, is something that's so common, but we can't forget, because it's especially important in patients with inflammatory disorders when they have chronic joint pain and muscle pain, is statins and myalgias. And you can see here, just a Google search, you can get over how many millions of hits you get within seconds on this topic. And this is a really important problem for many of our patients. But in a positive note, in 2023, we are at really exciting times because we have an expansion of cardiovascular imaging tools. We are much further beyond the exercise EKG and the basic echocardiogram, although those still have a large role in cardiovascular medicine. But you can see here, now it's almost like being a kid in a candy store. We have multiple imaging modalities. We have both coronary CT that allows the detection of plaque and the identification of stenosis. We have stress myocardial perfusion PET that allows us to diagnose microvascular health. We have cardiac MRI with the ability to add a stress component. And shown here is actually one of my patients with lupus pericarditis showing avid inflammation of the pericardium. So you can see here, the tools have been enriched, and we can utilize this to identify risk, which will be part of the purpose of what I'm going to be discussing today. You can see just on that list that all these modalities do create complexity. And we've recently published a JAK scientific statement on this article where we really talk about patients with our rheumatic systemic inflammatory disease conditions and discuss how we can utilize all these advanced imaging modalities for both diagnosis, risk stratification, prognosis, and monitoring. You can see here that we try to break it down across ischemic risk to structural risk, and then the level of the bed you're targeting. And then we go through every modality. I know at the Brigham, I'm lucky to have a lot of modalities in my toolbox, but these may not be available for everyone. And you can utilize different imaging tools to ask similar questions, and there's advantages and cons to each of these. And that's what this article really tries to do. Here shown is echocardiography and cardiac MRI. This next slide shows you coronary CT as well as nuclear imaging. So you can see here it is truly exciting times where we can really use these tools to be able to address cardiac risk in our patients. And taking a step back, as a cardiologist who trained in rheumatology with a passion in cardio-rheumatology moving forward, everything has changed in the cardiovascular community. The most groundbreaking trial was in 2017, led by Dr. Ricker, that was published in the New England Journal of Medicine, which was the first in the proof of concept study demonstrating that taking patients with known cardiovascular disease and treating them with an anti-IL-1 inhibitor, canakinumab, which blocks IL-1 beta, led to a reduction in cardiovascular events, which was really a truly groundbreaking trial given that proof of concept. More recently, we've had a number of studies that have shown the strong benefit of colchicine, a therapy that you're probably very well familiar with and have utilized a lot in terms of different conditions, gout, pericarditis in your own practice. But this has demonstrated dramatic risk reduction in patients with both acute events as well as stable coronary disease. And this mounting evidence for colchicine, which is easy to implement, actually led in 2023 the FDA to approve colchicine, which is really remarkable. This is the first anti-inflammatory drug in cardiology for reducing cardiovascular events. So we are at exciting times. And now I want to transition to talk a little bit about some of the common diseases we all study, but then I'm going to really walk through some cases of rheumatoid arthritis to really try to hone in these points of how we can identify cardiac risks and particularly how we can utilize imaging. So we all know that systemic lupus erythematosus is one of the common systemic inflammatory disorders that can predominantly affect young women, and it's associated with an increased risk of cardiovascular disease. There's a range of cardiovascular manifestations, but one of the most significant, of course, is accelerated atherosclerosis. And so we know from prior literature that among patients that are asymptomatic, patients with lupus have much higher rates of plaque. So atherosclerosis detected by CT in all age groups. This was really a seminal paper published in the New England Journal of Medicine now 20 years ago or 21 years ago. And you can see that this is that this problem persists in our patients with lupus. Going back to some of the older data, when we look at the Framingham Offspring study, you can see when you take those young patients with lupus, they have up to a 50-fold increased risk of myocardial infarction compared to healthy individuals in a cohort study, really demonstrating that we have unrecognized need here for improving cardiovascular outcomes in our lupus patients. Psoriasis is another important and very common condition, and one that we also study back here in Boston to try to understand how we can better reduce cardiovascular disease. Psoriasis and psoriatic arthritis is a chronic autoimmune inflammatory disease. It's common. It affects up to 3% of the population. And as you all know, up to 1/3 of these patients also have concurrent psoriatic arthritis, which is where you would be predominantly taking care of these patients. And at this point, it is well established that psoriasis is associated with an increased risk of cardiovascular disease and an increased prevalence of cardiovascular risk factors. This is just showing a very seminal figure in the field, again, back in 2006 in JAMA, led by Dr. Gelfand at the University of Pennsylvania, where he shows the relationship between the age and the severity of psoriasis and the risk of myocardial infarction. And I want to just clue you into the left of the chart. Look at the patients between 20 to 50 and look at the increased risk a patient with severe skin disease over mild skin disease has. And this really highlights the importance of inflammation and that this is indeed more than just skin deep. Third, we're going to be discussing rheumatoid arthritis, which is really where I want to be discussing the majority of my talk today to really hope to provide some insights into really what we're trying to understand by using rheumatoid arthritis. And so we all know it's a very common systemic inflammatory disorder that predominantly affects the joints. And at this point, again, well established that these patients are at increased risk. And if we just look objectively at the data, RA patients have about 1.5-fold excess risk of CVD when we compare them to age, sex matched individuals from the general population. And we believe this excess risk is attributed to that inflammation. And so we can think of RA as an independent CV risk factor and utilize RA as a human model of inflammation. And this is just work from our own institution. We have a longitudinal study at the Brigham and Women's Hospital called BRASS. And this is showing that our RA patients and their mean level of CRP compared to the general population, and where we think about CRP cutoffs for the general population. And you can see here that our RA patients live at much higher levels of systemic inflammation. And particularly about RA, we are really starting to understand more and more the disease mechanisms in these shared pathways. This is a recent review where Dr. Liao and I at the Brigham really, and Dr. Giles as well, really try to decipher this and discuss the key shared mechanistic pathways. So you can see here a joint, which we all know well in rheumatology, and on the right we can see here the atherosclerotic artery. And if we think about all these factors in atherosclerosis and the synovium and then the joint, we can see that there really are these shared pathways that are starting to diverge. And we're arguing, or we're proposing here, that it really seems to be pointing down this IL-1, IL-6 TNF pathway. And importantly, you all know that these are common treatments we utilize for rheumatoid arthritis. And in fact, we are now testing these for general cardiovascular diseases, which are very exciting. So I'm now going to transition to a case. We're going to walk through two cases to try to highlight how we can be identifying cardiovascular risk and importantly, how imaging can help us. And so my first case is a patient that I've been seeing now for well over 4 years. She's a 45-year-old female. She's got rheumatoid arthritis, and she presented with subacute worsening of shortness of breath and atypical chest pain. Here is her rheumatoid arthritis history. She was diagnosed 2 years ago and started on methotrexate, but she was still having active disease. So the next line of therapy was to add a TNF inhibitor. And at that point, she actually entered into a study at our institution, which involved a myocardial perfusion PET. And so I'll show you that on the next slide. But let's talk about her cardiac history prior to that. Well, she really had no known cardiovascular risk factors. She was premenopausal, and she did have hyperlipidemia that was untreated. She didn't know this, and this was her lipids here when I met her, but you can see this was untreated hyperlipidemia as a risk factor. Here's her CRP when I met her, and importantly, what was her risk score when we put her into the standard 10-year ASCVD calculator that we all utilize in cardiology? 1.1%, so low risk. Here I'm showing her cardiac perfusion PET, and I'm not going to go through the nuances of how to read a perfusion PET, although it is a very cool imaging modality, but I want to highlight here that we stress images on the top, resting images on the bottom, and the results of the scan showed a medium-sized area of moderate ischemia in the LAD territory. It also demonstrated normal GLOBE LV systolic function, but clearly a very abnormal result for a patient who's 45 and otherwise young and healthy, free of cardiovascular disease. So let's talk a little bit about PET and why I really think this is an important modality for us to really understand patients' risk. And the reason is that it provides a lot of imaging information. This test may not be available at every institution, but when it is available, it really does provide a comprehensive assessment of both the anatomy and the functioning across coronary artery disease. So I just showed you the perfusion images. So this is looking for like an epicardial or blockage. So that's focal disease. But look what else we get. We also get the atherosclerotic burden because you get a calcium score with your chest CT that you need for a PET scan. You can get LV function and volumes with the gated material here. And most importantly is the bottom right. You get the myocardial blood flow. And this myocardial blood flow allows us to detect microvascular dysfunction. This is not something that can be detected by the other imaging modalities you saw or by invasive coronary angiography unless you were to undergo specific microvascular testing. And this remains the gold standard for coronary microvascular dysfunction. So how do we actually understand and think about coronary microvascular dysfunction? Well, we utilize a term called the coronary flow reserve. And I want to tell you what this is. This is an integrated hemodynamic measure. So it's going to incorporate epicardial. So if you were to have a blockage, diffuse atherosclerosis, vessel remodeling, and myocardial tissue dysfunction on tissue perfusion. So we know from the perfusion images, there's no focal defect, then we can utilize the coronary flow reserve as a surrogate of microvascular function. How do we calculate this? Where patients undergo two different sets of pictures and we vasodilate the arteries to mimic as if you were exercising. And that's your myocardial blood flow at peak stress. And we divide that over the myocardial blood flow at resting. And what's a typical value? Well, this has been validated by Dr. DeCarli, my mentor who I train with and continue to work with, and multiple others. And in the established literature for clinical purposes, we utilize the coronary flow reserve as 2 as the normal cutoff. And when I say the normal cutoff for where risk starts to become highly important. So this is showing you an important study in the circulation, now actually 10 years ago, led by Dr. DeCarli group here at the Brigham, that demonstrated with a coronary flow reserve of 2, how much increased risk of MACE you have when that coronary flow reserve falls below that, and that it's equal between male and females. But this is for the general population. And so when I first started out in my scientific pursuits, we actually wanted to investigate whether this as a risk marker was similar prognostic in our rheumatology patients. And one may say it may not have the same predictive ability because our patients are at varied levels of disease activity and states of inflammation. And that led to a study that we led, as well as another study that had complementary data at the same time that looked at this question to say, is coronary microvascular dysfunction prognostic in our patients with rheumatologic disorders? Shown here is all-cause mortality from data from our own institution that looked at rheumatoid arthritis, lupus, and psoriatic disease, and we demonstrated the similar prognostic importance. The same figure on the right by the group at Yale also looked across different inflammatory disease conditions. Shown here on the bottom right panel, you can see they also included a small number of Sjogren's and scleroderma patients, and again saw dramatic risk increases with patients with low coronary flow reserve. So I just went through this whole thing telling you about coronary flow reserve, but let's go back to my patient, right? I was telling you that I met this patient. Well, what was her myocardial blood flow? I haven't gave you that data yet. So let's go back. So here's her data. So the way we look at these, and these are reported clinically in PET reports, is we have the stress blood flow, the rest, and the flow reserve. You can see here it's for all 3 coronary arteries, and we average. And her results led to a CFR of 1.9. So that is below 2 and highly, highly abnormal for a patient who's 45, female, without cardiovascular risk factors. So I'm seeing her in clinic. So this is, I am her cardiologist. So what did I do? Well, remember, she still had that LAD ischemia on the stress test. So we really wanted to make sure that we weren't dealing with a large blockage causing this reduction of blood flow. So we ordered a coronary CT to provide this data. And here I'm showing you her images here. And what these data demonstrated is that she had diffuse plaque. So she had no kind of critical blockage, but what she did have is she had diffuse plaque off all 3 coronary arteries. The predominant was non-calcified because she's 45 and young, and we know that calcified plaque takes time, so it's more common as you age, so that's another learning point. But she had really extensive atherosclerosis for her young age without cardiovascular risk factors. So again, let's take a step back here because I showed you on that first slide that her 10-year estimated risk was 1.1%. So no guidelines would have ever said this is a patient you should be initiating therapies and talking about cardiac risk. And let's just walk through here. So let's go through the exercise of utilizing our standard cardiovascular risk calculator. So here's our traditional cardiovascular risk factors. All she had was dyslipidemia that was diagnosed when we met her in clinic. Otherwise, she was negative for all these other risk factors. Here I'm showing you the 10-year ASCVD calculator that many of you may also know and go to the website or have programs that integrate this into your electronic medical record system. But you can see her risk comes up at 1.1%. And to just remind everyone, our primary prevention cardiovascular guidelines, the way we think about how to initiate prevention therapies is based on their level of risk. So this is just walking through it. It's a complicated figure, the reference is here, but I just want to highlight the notion that the level of risk that we start to think about initiating statin and prevention therapies is generally a risk of 7.5 and greater, or there is the borderline risk, this 5 and 7.5, where we utilize risk enhancers. And everything else is where we're really emphasizing lifestyle. What are the risk enhancers? And this is an important learning point today, is that these are the listed ACC, AHA risk enhancers that are in our guidelines. And in the 2019 update, I was so excited because they added inflammatory diseases. So now it is recognized as a risk factor. And this is because we have tried There are multiple disease-specific calculators out there, right? We've tried this for rheumatoid arthritis, and they may perform better in some cohorts, but not all. And that is why we probably all know and can appreciate here that these risk scores really underestimate risk in our patients. So we have to get better. And so let's just make sure I hone in on the key points here is that the 2019 update, inflammatory diseases is now a risk enhancer, so you can utilize that in your clinical practice. So let's summarize this case. So how do we treat her? So we have a 45-year-old female with active RA. She's got now non-obstructive coronary disease and significant microvascular dysfunction. So she was started on aspirin, statin, a beta blocker because of her symptoms of dyspnea and chest pain. And we discussed diet, lifestyle modifications, and her rheumatologist first initiated a TNF inhibitor, certolizumab. However, she did great for a couple of years, and as we all know can happen, her disease became active again, and she now has switched to a JAK inhibitor, and she has excellent control of her RA disease activity, which we don't have time to discuss in this short break today, but I know we're all very well of the JAK inhibitor data and all the subsequent data that has come out of this after the oral surveillance. But I did just want to highlight that this is a common thing I see in the cardio-rheumatology clinic is thinking through how we address risk in patients who are starting or who need to be on JAK inhibitors. And this is just a recent review where Dr. Garshik and I, as well as Dr. Shaw, a resident who led this effort, really kind of walk through how to think about risk stratification in patients who are initiating JAK inhibitors, utilizing our standard ways we think about identifying risk and addressing that risk among patients. And so the references here in case this is ever useful. I'm going to give one more other case to highlight another way we can identify risk. This is another patient in my clinic. He's a 64-year-old male. He's got rheumatoid arthritis on methotrexate, and he's coming for cardiovascular risk management after he had a scan that demonstrated new diagnosis by a coronary CT. So again, his risk factors were rheumatoid arthritis and then hypertension. Otherwise, he had a normal BMI, no other cardiovascular risk factors, and he was active. He was playing pickleball weekly. He did golf, no symptoms of chest pain. He had been diagnosed with RA in his 50s, and he had trialed TNF inhibitor in the past and didn't feel it worked well for him. So he was just being managed by methotrexate. Here are his labs in clinic, including his lipids. Lipoprotein A is a very important cardiovascular risk marker and emerging more and more data on the importance of this. And this is just showing you here that his lipoprotein A was normal, as well as a fairly normal LDL and a normal A1C. So he got referred because he had this data, which is a coronary CT scan. And again, just to show you really what this demonstrated, I hope you can see some of the plaque and blockages here, but there was an extensive amount. So we grade our coronary CTs based on CADS-RADS severity, and he had the highest severity. He had extensive amount of diffuse plaque. He also had total occlusion of a vessel, as well as evidence of a prior missed heart attack. He had a basal wall aneurysm of his heart that was thinned out and hypokinetic, including multiple severe to moderate blockages throughout his main coronary arteries. So this was a shock to the patient, a shock to kind of all of us. But again, identifying this risk. This risk could have also been identified by a coronary artery calcium score, something that I utilize very frequently in my clinic to identify atherosclerosis. And why is identifying atherosclerosis so important? And it's important because of many reasons, but just a few key facts to remember. Most stress tests are normal. Most events occur in patients, even with the normal function study. And if we look at the data that's accumulated, we now know that the plaque burden predicts risk much better than one single stenosis. So that is why identification of plaque and initiation of prevention therapies is so critical. And we can use that. We can identify that with very standard therapies, including just a chest CT, if any of your patients have had one, to look for atherosclerosis by calcium. And so what did we do with this patient? Well, we initiated aspirin, high-dose statin. He continues to feel well without symptoms. And more recently, we added colchicine, given that he had had a prior heart attack and he continued to have elevated CRP with extensive plaque. And so that leaves me some food for thought questions. I showed you on that first slide that colchicine has proven cardiovascular risk reduction benefit but we have not yet tested it in our patients with rheumatologic conditions in this scenario. But one can may ponder, so a few for future thought when we're talking about the science here is, would this patient benefit from changing his immunomodulator to reduce to reduce his cardiovascular risk? And going back to that slide where I showed you the shared atherosclerosis, we are now seeing that both these key pathways, that we have drug targets that are being utilized both in the rheumatology space, again, way ahead of cardiologists over here, look at the left, but we are now testing ziltivekimab, which is an IL-6 inhibitor across coronary artery disease, both acute and chronic, and heart failure with preserved ejection fraction. So we are really starting to see emergence of these pathways. And so to conclude, I know this was a short tour de force, but I hope everyone found some interesting learning points, but really trying to hone them in here. I hope I emphasize that a low ASCVD risk score and or the absence of symptoms in a patient may not be reassuring in patients with our systemic inflammatory disorders. These two cases, I hope, exemplify the importance of identifying microvascular dysfunction and non-obstructive atherosclerosis to initiate those prevention therapies. And we discussed tools such as PET myocardial perfusion and CT and coronary CT and how they can be complementary. Identification of plaque allows us to add on appropriate therapies to reduce risk. But the key for the future, as all of us moving forward, is we really need to understand this: whether initiation of disease-specific immunomodulators results in the improvement of vascular health is really not known, and that's where it's currently investigated in multiple prospective studies. So is one DMARD differential on cardiovascular risk than others when you're getting down to the level of this sophistication? And so just to sum up, it is truly impossible for everyone here in the audience to address everything in your clinic. We need early recognition of cardiovascular risk. We need risk stratification, weight loss, lipid management, blood pressure management, lifestyle, hence the need for collaborative care. Isn't that a mouthful? And so that is why I truly believe there's a strong need for cardio-rheumatology and multidisciplinary care models, and we have a lot of work to go. Here is just showing you some building blocks that you can see on this slide here. And most importantly, in addition to building all the science and building we need awareness and education for our patients and building the community, because ultimately what we're trying to do is prevent cardiovascular disease. Cardio-rheumatology is growing globally. These are just showing you some of the conferences we have both global and across the United States. And so if anyone is interested, please do reach out to me because we have multiple educational opportunities throughout the year. And then I would just want to thank RheumNow for the opportunity to speak today. I want to thank all the rheumatologists that I work with, including one of my main mentors, Dr. Liao, all the cardiologists I work with, as well as my funding to do the science that we do, and most importantly, the patients that I see in the cardio-rheumatology clinic at the Brittany. So with that, I'll stop, and I look forward to seeing you guys live on the discussion. Thank you again.